Great. Thank you so much, Wade. Hi, everyone. As Wade and Doris mentioned earlier, I'm going to be joining the Nerd Night crew as an organizer. And so I guess this is my trial by fire tonight. So I either sink or swim. Thanks for that. So I'll introduce myself first. I'm Allison. I'm actually a software engineer in blockchain at IBM Research. But when thinking about what talk I would give at a Nerd Night, I heard that there was actually a blockchain talk in the last year, and to be honest, I'm not sure how much content there is on blockchain to keep everyone entertained. So I decided to talk about what I used to work on when I worked at St. Vincent's Institute before I worked at IBM, which was islet transplantation. And so just to check that I've got this right, that it's an organ transplant that you've probably never heard of, who here has actually heard of islet transplantation before? 1, 2, 2. Okay. That's kind of expected. It's because it's a relatively rare procedure, and it's also quite new. I think the first transplant in Australia happened just over 10 years ago. So before I start on the actual transplant procedure itself, I thought I'd give a bit of background on the disease that it treats, and that is type 1 diabetes. So type 1 diabetes is also known as juvenile diabetes or early onset diabetes because it tends to come on in young kids, generally when they're under the age of 10. So it's an autoimmune disease where the immune system seeks out and kills beta cells, which are the cells that produce insulin. So insulin is a very important hormone. It's used to regulate blood glucose levels. So when glucose levels in our blood get too high, our beta cells release insulin, and the insulin tells the rest of our cells in the body to absorb that excess glucose, especially our muscle cells, and that will bring the levels of glucose back down to normal levels. So the insulin-producing cells are found in structures called islets of Langerhans that are found distributed throughout the pancreas. So this is a slide of microscope slide of pancreas tissue. The light pink tissue is the islet, and the darker pink tissue is the rest of the pancreas tissue. So islets make up about 2% of the pancreas mass, and the rest of the pancreas actually is responsible for producing digestive enzymes. So there's no cure for type 1 diabetes. People with the disease need to manage their blood glucose levels by constant monitoring, usually with a finger prick test, which takes a little sample of blood to measure how much glucose is in there. And then they need to take multiple insulin injections every day to make sure that their blood glucose levels are within the normal range. So the management of type 1 diabetes has improved dramatically over the years with things like long-acting insulin and insulin pumps. However, there are some serious long-term side effects of diabetes. So people with type 1 diabetes have an increased risk of cardiovascular disease, of eye disease like retinopathy, and kidney disease. So I think the statistics is 2 to 4, people with type 1 diabetes are 2 to 4 times more likely to get heart disease than the rest of the population. And they also have life expectancy around 10 years less than the rest of the population. So these are not very nice statistics, I'm sorry to have to tell this story. So the way doctors try to deal with type 1 diabetes is to get their patients to take insulin injections to keep their blood glucose levels down as close as possible to normal levels. And that's done through insulin injections. But there is a hidden danger with insulin injections, and that is hypoglycemia, which is too low levels of glucose in the blood. So symptoms of hypoglycemia include dizziness and disorientation. People can have loss of consciousness, coma, and even death. And there exists this syndrome, which is terribly named. It's called dead-in-bed syndrome, so people with type 1 diabetes have a risk of this, and it's where levels of blood glucose drop to fatally low levels while people are sleeping. Thankfully, this is not a common occurrence. Most people with type 1 diabetes are able to safely manage their blood glucose levels with insulin injections, but it is a risk. Excuse me. And so there is a certain subset of the population which are also at risk of hypoglycemic episodes or hypoglycemic unawareness, which is where they can't sense when their levels of glucose in their blood drop too low. So these people are at risk of falling unconscious at any time. They often can't drive. They can't swim in the pool with their kids, sorry, unsupervised, and they can't cook at a stove with the fear of falling unconscious because their blood glucose levels fall too low. So there is hope, and that is islet transplantation. And with this procedure, it can be a life-saving option for them. So this is a schematic of the islet transplantation procedure. What happens is the pancreas is taken from an organ donor. Thank you very much. I might have a sip. Sorry. So the pancreas is taken from an organ donor, and instead of transplanting the entire organ, the islets are removed from the rest of the pancreas tissue. So this is done because the pancreas is quite a large organ. It's about 100 to 200 grams. And as I mentioned before, about 98% of the pancreas tissue is actually used to produce digestive enzymes, which is not very useful for someone with type 1 diabetes. What people with type 1 diabetes need is the islets, which are the little structures that produce the insulin. So what we do is we separate the islets from the rest of the pancreas tissue. This ends up with a very small quantity of tissue, which is then able to be injected into the liver of a recipient in a relatively non-invasive procedure. So it's done through a simple injection. And this is as opposed to the way the organ transplant would be done if it was the entire organ, which is where a surgeon would have to open up the patient and then rewire all of the blood vessels of the pancreas. So it's this procedure, which is the separation of the islets from the rest of the pancreas tissue, which is what I was involved in when I worked at St. Vincent's. So this is the clean room facility at SVI. The clean room has this big machine that's called an isolator. The isolator is a sterile and highly regulated environment that's used to process human tissue for therapeutic purposes. So it's funded and operated by these 4 organizations here. So what happens is the pancreas arrives at the facility, and from the time that it arrives until the time that the islets are taken to the hospital for the transplant, it all happens inside the isolator. And a team of about 4 or 5 people, work in this isolator to do all of the processing of the pancreas. We put our hands in these gloves and do all of the manipulation through the gloves. The isolator is an incredibly cool piece of engineering, and to be honest, I could talk about that all night, but I won't bore you. So when the pancreas arrives at the facility, it looks a little something like this image up here. It has the spleen attached and the duodenum, which is part of the intestine, and it's covered with a layer of fat. So the first job is to trim all of the excess tissue from the pancreas. And when that's done, it looks something a little bit like this image at the bottom left. It's then injected with purified enzyme that's used to digest all of the connective tissue that holds the pancreas together. We then chop up the pancreas into small pieces and place it in a chamber with metal marbles and shake it vigorously in order to break apart all of the pancreas tissue. And what we're left with at the end of that process is this image on the left. So this is a sample of the digested pancreas. The little red balls are the islets, and the cream balls are the rest of the pancreas tissue. So they've been stained with a substance called dithazone, which actually binds to the zinc particles, of which the beta cells and the other cells in the islets contain a lot of. So to separate the islets from the rest of the pancreas tissue, we take advantage of the fact that islets are less dense than the rest of the tissue. So we form a solution that's a continuous density gradient. So the solution that's at the bottom is highly dense solution. The part at the top is less dense, and it's a continuous gradient in between. So we spin that really fast on a centrifuge, add the islets to it, or the tissue to it, and the islets actually, when it's spinning, separate from the rest of the tissue. We're then able to collect that islet fraction from the top, and what we end up with is something that looks like what's on the right here, so a highly purified fraction of islets. At this stage, there's about 5 to 6 milliliters of tissue of what was once 100 to 200 gram pancreas. So that whole process, from the time that the pancreas arrived at the facility to having these purified islets, takes about 6 hours to complete. And it always seemed to happen overnight. But the process doesn't stop there. Because the recipient needs to go on lifelong immunosuppression, it means that we have to do some rigorous quality control checks to ensure that what we put into the patient is going to have some positive outcomes for them. So we test for contamination, that we make sure that the preparation that we put into the patient is going to be safe. And we also check for the number of islets and the viability of the islets. So if the preparation is not good enough for transplant, it usually goes to the Institute for Medical Research. But if it does pass, then at that stage, the recipient is called into the hospital for the transplant. Sorry. Okay, so because at this stage, the tissue volume is so small, about 5 to 6 milliliters, it means that the transplant procedure is so different from a normal organ transplant. So instead of a surgeon, it's actually performed by a radiologist. The patient is actually awake, under a light sedative and just local anesthesia. So what happens is the radiologist puts a cannula into the portal vein of the liver. So you can see that on this image on the right. See if this works. Not so well. That's the cannula there. The radiologist also inserts a dye into the cannula, and that highlights all of the blood vessels of the liver, which you can see in that image on the right. So when the radiologist is certain that the cannula is in the correct position, they attach the bag of islets. So the islets are in about 100 ml of solution at that stage. So they attach the bag of islets to the cannula, and the solution is able to drain via gravity into the liver of the patient. So the islets then disperse throughout the pancreas and lodge in the really tiny blood vessels of the liver. So the liver might seem like a strange place for a transplant. Why not just put it back into the pancreas? And the reason is because the islets need a really high level of blood supply in order to function correctly. So when insulin is released, it's released into the blood, and then it travels via the blood to the various places in the body where it acts. The liver is a large organ, and it's highly vascularized, which means that it has a really high blood flow, like lots of blood vessels. So it's the best place that we've found to put the islets for transplant. It's still not ideal. We found that about 10 to 20% of the islets actually survive this procedure, but it's the best we've got so far. So this is what happens at the end of an islet transplant. This is blood glucose levels of a patient before and after an islet transplant. Each of the lines on these graphs represent a different day of blood glucose monitoring. So you can see before the transplant, there were large fluctuations in blood glucose levels. And then after the transplant, blood glucose levels returned to almost normal levels. So The recipients of an islet transplant are always those people who have uncontrollable type 1 diabetes. They're the people who have these hypoglycemic episodes, the low blood sugar level, that they can't sense, so they have that risk of falling unconscious. So the main aim of the islet transplant is to restore glycemic awareness. So these people can tell when they're having an episode and can eat lollies or have some form of glucose in order to bring their levels in their blood back up to normal levels before it becomes dangerous. But what we actually find is that people who have 2 islet transplants are able to become insulin independent. So that means that they're no longer required to have daily insulin injections. So it's pretty cool. The trade-off to this, obviously, is that these people need to take lifelong immunosuppression, and that's in order to prevent the body from rejecting the transplant, and also to prevent the body from attacking the beta cells the way that it did their own beta cells. So there's some research happening right now on ways to do islet transplants without requiring the immunosuppression, and that's by encapsulating the islets in some sort of immune impenetrable barrier. So that research is about 10 years away, probably, from being commercially viable, but it's something to keep an eye out for. So just before I finish up, I want to give a shout out to Donate Life. They're the organisation that manages all of the organ transplants across Australia. The islet isolation team at St. Vincent's Institute, they work really long hours doing these islet isolation procedures and all of the quality control checks. And also the team at St. Vincent's Hospital, so they manage the waiting list for the islet transplants and all of the patient work, as well as the actual transplants themselves. Thank you.
Thank you, Allison. Thanks for helping us learn about inlet transplants. I had no idea what they were until we had a conversation about it. We'll take some questions. Yep.
Since you answered all the other questions, what brought you from this topic to blockchain?
What's the connection between inlet transplants and blockchain?
There's not really much of one, I'm sorry. I kind of got up to the point in my research career where they asked me to either do a PhD or, and I didn't really, I know a lot of you probably have your PhDs, but medical research is a really hard career, and so I still wanted to do something that involved my brain, so I went back to university, I studied engineering, and now I'm a software engineer. It's not related at all. Such a waste.
Multi-talented. We'll take a question over there. Yep. You, yep. Might have to get you to speak up a bit.
I think the question was if it's widely known. So if people with type 1 diabetes are able to access this, is that correct? So because it's an organ transplant, it requires going on immunosuppression. Only people who have quite severe type 1 diabetes are eligible for the program. But I think that they are trying to get the story more widely known in the community so that they can find people who are struggling with managing their type 1 diabetes to come to the hospital, get tested, see if they're eligible. So if you want, I'm happy to pass on the name of the clinician at St. Vincent's Hospital who manages all of this. If she has any questions or wants to find out more, she can do so.
Great. Sharing knowledge at midnight. Yep, we'll take one here. What's the waiting list?
It really depends. So before we do any of the transplants, we actually have to match the donor with the recipient to make sure that their immune types aren't too different, that the recipient will reject the organ transplant. I'm not sure exactly what it is. It might be 1 to 2 years, because it really depends on when we get, or when the team, I should say, gets a pancreas that's good enough for the islets to be transplanted.
Yeah. And we'll take one question here. Yeah.
In vitro.
Can you grow islets?
Or grow them, or just culture them?
Culture them?
Yeah, so in terms of culturing them, the islets that we get for the islet transplantation, they end up being in culture for around 24 to 48 hours. That doesn't seem to have too much of an impact on the viability of the islets, but any longer time after that, they will start to deteriorate. So I think we're struggling in keeping islets viable in culture for long times. But there are various beta cell lines, which are basically cancerous types of beta cells, which can be cultured in vitro. And they're doing experiments with those cell lines right now, putting them in devices where the growth is controlled by the physical volume of the device, and putting that into people with type 1 diabetes. But that's highly experimental at this stage.
Did I see someone put up their hand by shining a torch on their phone? No? Okay, that was really smart. I'm going to give you a bag of candy for that, given the topic that we're talking about. What's your question?
Because so many young people are affected by type 1 diabetes, I'm just curious, sort of all the other questions about, like, does the transplant tend to do it more for young people who have a longer expectancy, or is it more adult?
Ooh, good question.
Yeah,
How do they pick transplant patients?
It's usually not. I don't have the statistics off the top of my head, but I think the recipients tend to be a little bit older, probably, I'm not sure, but in their 40s, 30s, 40s, 50s. And I think the reason for that is these islet grafts, they don't last forever. And so putting them into young people means that they'll be on immunosuppression for a longer period of time, and also it means that they'll need top-up transplants as time progresses. And after the first transplant, it gets harder and harder to do subsequent transplants because your immune system gets primed to the different cell types and will be more likely to reject cells. So I think that's why these transplants tend to happen a bit later in life.
We'll take one last, 2 questions, Mike. We'll take one here and next one there. Yeah.
How many people in Australia have had these islet grafts so far?
How many transplants has occurred?
This is something I was actually looking at today because I thought this question might come up.
Do you have a slide prepared?
I do not. Should have spoken to Eric beforehand, but no, I don't. I think it's in the tens. It's not a whole lot. Yeah, tens of people. Yeah, it's quite a rare procedure.
That was your question. 2 in 1. That's
2 with 1.
excellent.
Yeah.
And yeah. All right. We'll take that question from Dan.
Research being done on extracting islets from living patients rather than waiting for pancreas to be donated. I've seen it.
Sounds a bit like inlet harvesting to me, but
So there's one. I'm not sure that this answers your question completely, but there is a procedure that's called an allo islet or auto islet transplant, I should say, where people with chronic pancreatitis who need to have their pancreas removed because of the inflammation, we actually do islet isolation from them and transplant their own islets back into their liver after that procedure. But I'm not sure that's the question you are asking. Yes. Yep. Yeah. Look, I have never heard of that before. I'm not sure if it would be possible to take half of a pancreas and still have the other half of the organ work the way that it's supposed to in the donor. It's not something I've heard of. I can't tell you for sure that it hasn't been done.
thank you so much for that, Allison. She's also an avid